reasons which we all know, prevailing reason, prevailing conditions. We are here, and the MAMC team with Dr. Bijay Lakshmi Sahu presiding over today's e-clinical meet. They are our host, and we are very much thankful to Dr. Anil Ganju sir for accepting the guest lecture session. So friends, we will be having a very good brainstorming session, including a guest lecture session on urticaria. I hope that it is going to be fruitful to all of us. So I am handing over to Bijay Lakshmi Sahu.
Thank you, Dr. Vinay Singh, our President, Iadvl DSB. Respected seniors, colleagues, and dear students, a very good afternoon to you all. On the behalf of Department of Dermatology, MMC and Associated Lok Nayak Hospital, I welcome you all to the third e-clinical meet at MMC. It's my pleasure to convey that Lok Nayak Hospital has been rewarded Best Government Hospital in India for combating COVID-19 in 2021. This could be possible because of hard work by our residents, doctors, healthcare professionals, and also due to able administration. I hope you all will enjoy the discussion of interesting cases in this forum. I thank the President, Honorable Secretary Dr. Gaurav Nakra, for giving us an opportunity to conduct this e-clinical meet at MMC. With this, I hand over the mic to Dr. Gaurav Nakra, Honorary Secretary to DSB Iadvl, to introduce Dr. Garima, Assistant Professor, and also to start the proceedings. Thank you. God bless us all. Thanks.
Good afternoon, everyone. Good afternoon, Dr. Bijay Lakshmi ma'am. Thank you for the kind words of introduction, and thanks on behalf of Iadvl for hosting us today. And I'm sure that it's going to be a great learning experience for all of us. With these words, I introduce Dr. Garima, who is Assistant Professor in the Department of Dermatology, MAMC, to take over the proceedings.
Good afternoon, respected faculty members and dear delegates. We have 7 interesting cases lined up for today. I humbly request you to keep your mobile phones on silent mode and microphones on mute. If you have any queries, please type them in the question box. The queries will be discussed after the respective cases, and the remaining queries will be answered at the end of the session, if time permits. Now, without further ado, I request Dr. Anjali, final year postgraduate student, to please present the first case. Dr. Anjali, please.
Dr. Anjali, you are not audible, I suppose.
Hello.
Yes. Please continue.
Okay. Good afternoon, everyone. Good afternoon. Thank you, ma'am. Good afternoon, everyone. I'm presenting the case of a 6-month-old male infant. Informant was mother, a 6-month-old male, known case of chronic granulomatous disease, who was admitted in pediatric ICU and was referred to us with chief complaints of multiple red raised itchy lesions on face and extremities since 3 days. The lesions were acute in onset, appeared overnight, and progressed from legs and feet to involve buttocks, upper limb, and face within a day. A provisional diagnosis of papular urticaria was made, and patient was advised antihistaminics topical steroids, and antibiotic combination. However, he took only antihistaminics. After 7 days, redness, number, and size of the lesions increased, and some lesions appeared tender. There was history of redness and swelling at the BCG injection site 2 weeks prior to the appearance of lesions. However, an FNEC from the same was not done by the parent department. There was history of multiple admissions since birth in view of on and off high-grade fever, pustules and abscess over scalp, swelling of toes, and bloody stools. The patient was born out of non-consanguineous marriage, fully immunized, and developmental milestones were normal. There was history of death in maternal uncle at 6 months of age due to unknown reasons, and there was history of abortion in the mother at 1.5 months, 1.5 years back, and this was the firstborn child who was affected. The patient was on multiple antibiotics like linezolid and meropenem in view of high-grade fever, and metronidazole was started in view of stool examination showing entamoeba histolytica. Injection DEXA was started in view of a suspicion of hemophagocytic lymphohistiocytosis. However, it was ruled out afterwards. However, there was no relation of drugs with the onset of cutaneous symptoms. On examination, the general physical examination, vitals, and systemic examination of the patient was normal. On anthropometric examination, the length of the patient was between -2 to -3 standard deviation, that is, stunting was present. On first day of the examination, we noted presence of multiple erythematous papules, few of which were excoriated, and the lesions on the face showed presence of punctum. These lesions were also present on bilateral upper limbs and lower limbs. Further, on day 15 of examination, we noted presence of multiple bilaterally symmetrical tender erythematous nodules. This measured in size from as small as 1 × 1 centimeter to as large as 3 × 3 centimeter, and these lesions were present over the face, bilateral upper limbs, buttocks, and bilateral lower limbs. Based on a history and examination, a provisional diagnosis of BCGiosis with erythema nodosum was kept. On hematological investigations, hemoglobin and platelets were low. TLC, CRP, LDH, and ferritin levels were found to be raised. Stool microscopy showed presence of Clostridium difficile and entamoeba histolytica, and a nitroblue tetrazolium test was performed, which showed a phagocytic activity of only 0.1%, which confirmed the diagnosis of chronic granulomatous disease. On performing an ultrasound left upper arm, there was a well-defined hypoechoic lesion, and few internal echoes in the intramuscular plane at the site of BCG vaccination was present, which was suggestive of post-BCG abscess. A sputum and gastric aspirate was sent for acid-fast bacilli, which was negative. This is a chest X-ray view, AP view of the showing multiple nodules in bilateral lung fields. An axial NCCT of the chest showed presence of patchy consolidation surrounded by ground glass opacification in the apicus segment of the right lobe. An NCCT of the an axial section of the middle lobe showed presence of multiple nodules in both middle lobes of both the lungs. And an axial section of the lower lobe showed presence of a single subpleural nodule, which showed cavitation in the right lobe. A photomicrograph of 10x section of HAD showed a normal epidermis, a periadenixial chronic, perivascular chronic inflammatory infiltrate, as well as in subcutaneous tissue, we could identify both septal as well as lobular inflammation. On a higher magnification, that is 40x, we could easily make out the lobular as well as the septal paniculitis that was present. And on a higher magnification of this, we noticed that this infiltrate was composed of both neutrophils as well as lymphocytes. Zetin stain for acid-fast bacilli was sent, which was negative, and a PCR for Mycobacterium bovis subspecies was sent from the erythema nodosum-like lesion, which was also negative. Purpose of this case is discussion.
The case is now open for discussion. If anybody has any queries, please type them here. Since there are no queries at the moment, we'll take up the queries later. Dr. Anjali, please continue your case.
Okay, ma'am. The patient was empirically started on anti-tubercular therapy. Tablet isoniazid, rifampicin, ethambutol, and ofloxacin was started. Fever subsided, and approximately 40% of the cutaneous lesions improved within 2 weeks of starting anti-tubercular therapy, and approximately 80% improvement was there in the cutaneous lesions after 4 weeks of anti-tubercular therapy. This is the disease course. Initially, the patient presented with papillary urticaria-like lesions, which later progressed, and we could see presence of erythema nodosum-like lesions. And here we can see almost complete clearance of the lesions after 2 weeks of starting anti-tubercular therapy. Pointers towards our diagnosis includes presence of a primary immunodeficiency disorder, which in this case was a chronic granulomatous disorder. And in most of the cases, it has been seen that BCGiosis in most of the cases is associated with the primary immunodeficiency disorder. An age of 6 months, since in most of the cases, it has been seen that BCGiosis presence in the patients within 6 months. A history of BCG site inflammation and presence of subcutaneous abscess at the BCG site on ultrasound, which was followed up by the appearance of erythema nodosum-like lesions, which is a cutaneous marker of underlying tuberculosis. A persistent fever that responded to anti-tubercular therapy, and a chest X-ray and CT evidence of tuberculosis. There were several atypical presentations of our case. For example, an atypical progression from papillary urticaria-like lesions to erythema nodosum-like lesions, and an atypical histology. The incidence of disseminated BCG infection or BCGiosis is 1 per 230,000 to 640,000. That is, it is rare. The BCG vaccine is a live attenuated strain of Mycobacterium bovis subspecies, and adverse reactions to BCG vaccination usually occurs within the first 6 months. BCG disease, as has been classified by Hesseling et al., can be of 4 types: localized, regional, distant, or disseminated. If there is presence of a BCG site abscess more than equal to 10 millimeter or BCG scar ulceration, we classify it as a localized disease. Presence of lymph node involvement or other regional lesion beyond vaccination site is said to be regional disease. Any ipsilateral site involved beyond the local or regional area, and if Mycobacterium bovis subspecies can be confirmed from at least one site beyond vaccination site, it is a distant disease. And Mycobacterium bovis subspecies, if it can be confirmed from more than one remote areas and or from at least one blood or bone marrow culture, it is a disseminated disease. Both localized and regional disease are together known as BCGitis, and distant and disseminated diseases are together known as BCGiosis. The diagnostic criteria as given by European Society for Immunodeficiency includes systemic symptoms such as fever or subfebrile states, a weight loss or stunted growth, at least 2 areas of involvement beyond the site of BCG, which was present in our case, identification of Mycobacterium bovis BCG subspecies by culture or PCR, and the typical histopathological changes with granulomatous inflammation. After these 4 points, we also propose that response after an anti-tubercular therapy trial should also be included in these criteria for the diagnosis of BCGiosis. Since most of these patients have an underlying primary immunodeficiency disorder, and if at all a primary immunodeficiency disorder is present in a patient, there can be many atypical manifestations can be present. And if a fast diagnosis and prompt treatment is not given, the mortality rate of the disease is very high. So this is one of our recommendations. This is my review of literature. There has been a study in China in 2014, which was a 6-year prospective follow-up study. And the mean age of onset of patients with BCGiosis is seen to be 3 months. And most of the patients, 57.14% patients of BCGiosis were seen to have an underlying primary immunodeficiency disorder, most commonly being chronic granulomatous disease, as in our case. And they mentioned the cutaneous features as a BCG site abscess. These are my references. Thank you.
If there are any questions or queries, please ask. Dr. Anjali, we don't have any questions for you at the moment. We'll discuss the questions related to your case later. Thank you, Dr. Anjali, for presenting such an engaging case. I now request Dr. Gajanan, second year postgraduate student, to please present the next case. Dr. Gajanan, please.
Good afternoon, everyone. Today I am presenting a case of 35-year-old female who is a resident of Ghaziabad, Uttar Pradesh. Presented over OPD with the chief complaints of single dark-colored itchy lesions on the glabella for the past 5 years. Initially, the lesions were red in color, which progressed to dark color lesion over the 4 to 5 months, and also associated with the itching, which exacerbate on the sun exposure. And patient also gives the history of application of indigenous red powdered kumkum on the same site for the past 5 years. And there is also history of occasional sticker biji application. Patient also applied some topical creams which are prescribed by the local doctors with a partial relief. Past family and personal history are not significant. On examination, general examination, vital signs, and systemic examination are within normal limit. And this is a photograph of showing the indigenous kumkum which the patient used to apply in the glabella area. And she used to apply the liquid kumkum over the forehead region, which was not present at the time of presentation. On mucocutaneous examination, there is a presence of the single ill-defined brownish hyperpigmented macula of size 3 to 2 centimeter present over the glabella with the presence of the remnant red kumkum, and there is a presence of the hypopigmented area inferiorly. Based on the clinical history and the examination, we arrived the provisional diagnosis of kumkum dermatitis, contact dermatitis secondary to the kumkum application. And in later, the patient investigated with the patch and photopatch test using Indian standard series, Indian cosmetic and fragrance series, and patient own compound, which with Indian standard and cosmetic series with the systemic laboratory of India. And results read after the 96 hours, and the patient shows a strong positive reaction for the as it is compound. And the patient also shows the weak positive reaction for PPD, musk mix, and chloroacetamide, twin 80, geranium oil, and rose oil. And patient was patch tested, and the results were showed that patient showed the strong positive reaction for the nickel. This indicates the patient is photoallergic contact dermatitis to the nickel. Here, in non-irritated side, there is no reaction. On the irritated side, patient showed the strong positive reaction. Finally, patient is allergic to the PPD. This can be explained by a cross-reactivity of the PPD with the azodyes. Azodyes are known to be present in the kumkum, so it has got a definite relevance. And the nickel is shows a strong positive photoallergic contact dermatitis. Then this has got a definite relevance. Musk mix, geranium rose oil, which are used as a fragrance in various cosmetic series, including kumkum. So this has got a probable relevance. And chloroacetamide and twin 80. The positivity can be these are used as a preservative or the emulsifier in various cosmetic products or the paints and other things. So the positivity can be this antigen can be explained by previous exposure of these antigen to with the patient. Finally, to the best of our knowledge, this is the first case which reveals the photoallergic contact sensitivity with the nickel and contact sensitivity to geranium oil, rose oil, musk mix in the kumkum dermatitis. And all the patient of kumkum dermatitis should undergo patch test and photopatch testing. And similarly, chemical analysis should be undertaken to confirm the presence of these hidden allergens in the kumkum. Thank you.
Thank you, Dr. Gajanan. We don't have any questions for you at the moment. I now request Dr. Bhavishya, a final year postgraduate student, to kindly present the third case. Dr. Bhavishya, please.
Good afternoon, everyone. I'm going to present a case of a 56-year-old male resident of Delhi who presented to us with chief complaints of persistent itchy red rash on the left nipple since 6 months. Patient initially experienced continuous itching on the left nipple, which subsequently developed into red scaly lesion involving the entire nipple and the areola. There was history of application of multiple cream which transiently relieved the itching, but the lesion persisted despite treatment. There is history of oozing from the lesion. However, there is no history of oozing from the nipple, bleeding, or pain. There is no history of breast lumps, multiple swellings in the body, weight loss, or fatigue, no history of other comorbid conditions, no history of breast cancer or similar lesions in the family. General physical examination and systemic examination revealed no abnormalities. On examination, there was a single erythematous, well-defined, irregular plaque of size 4 into 4 centimeter located on the left nipple with lesion extending into and beyond the margins of the areola. The surface of the lesion shows scaling with erosions and fissuring on the nipple. On palpation, the lesion was non-tender and soft to firm in consistency. There was no evidence of breast lump on palpation, no spontaneous nipple discharge or discharge on applying pressure. The contralateral breast revealed no abnormalities or asymmetry. Examination of the bilateral axilla did not reveal clinically significant lymph nodopathy. On the basis of the history and examination, a provisional diagnosis of mammary Page's disease was made. We proceeded to conduct few investigations, first to confirm the diagnosis, second to rule out the underlying malignancies. Slit skin smear was performed in our side lab, which under high magnification revealed clusters of large cells with pale cytoplasm and enlarged nucleus, which is suggestive of Paget's cells. This being a quick bedside test supported our provisional diagnosis of mammary Paget's disease. To confirm our diagnosis, we conducted skin biopsy for histopathological examination and immunohistochemical markers. In 10x magnification, we can see epidermis is hyperkeratotic with acanthosis, and we can also see perivascular inflammatory infiltrate in the dermis. As we can see here, the basement membrane is intact. Zooming in further, we can see multiple enlarged cells with pale cytoplasm lined up along the basement membrane zone, basement membrane. And again, here we can see the basement membrane is intact with dermis showing chronic lymphocytic infiltrate. This is the higher magnification showing enlarged cells with pleomorphic nuclei. Immunohistochemistry markers shows CK7 and HER2 positivity, while the hormonal markers like estrogen receptor and progesterone receptor and CK20 were negative. Findings in the ultrasound breast and axilla were unremarkable. So a final diagnosis of mammary Page's disease was made. The patient underwent modified radical mastectomy, and the breast tissue along with the lymph nodes were dissected and they were sent for histopathological examination. The patient is currently being followed up and is on post-op day 2. The purpose of this presentation is demonstration of a rare case of a Page's disease in a male patient. Page's disease can be classified into mammary and extramammary Page's disease. Mammary Page's disease is an intraepidermal adenocarcinoma of the nipple and or the areola with or without underlying breast malignancy. These are the treatment options offered: simple mastectomy with or without axillary lymph node dissection, breast conserving surgery followed by whole breast radiotherapy, or modified radical mastectomy. Cases of breast and cancer male breast is rare, and it constitutes 0.5% of the cases of breast carcinoma, and mammary Page's disease in males is extremely rare. So far, 26 cases have been reported till date, and out of which 5 cases in males are without underlying malignancy. These are my references. Thank you.
Thank you, Dr. Bhavishya, for presenting such an interesting case. We don't have any questions for you at the moment. Now I request Dr. Vishal, second year postgraduate student, to kindly present the 4th case. Dr. Vishal, please.
Thank you, ma'am, and good afternoon, everyone.
I am presenting a case of 55-year-old male, farmer by occupation, residents of Delhi, presented with chief complaint of paleness, swelling of the right foot finger. There is a swelling of the third finger of the right hand with discharging sinus from the past 2 years, and there are multiple discharging sinuses present over the left side of the chest for the past 1 year. So patient presented with the swelling over the right foot, which was initially localized over the midfoot area, which gradually increased to involve the whole of the right foot in the next month span, and is associated with the overlying multiple sinuses with purulent, viscous, serous and non-foul swelling discharge. Similar lesions were also present over the right third finger as well as on the left side of the chest. There is a history suggestive of extrusion of the bony spicule from the discharging sign of the finger with no history of discharge of granules. There is a history of barefoot walking on open ground with no history of any preceding trauma. There is no history of fever, cough, or any other any symptoms suggestive of pulmonary tuberculosis. Patient is having history of acral vitiligo for the 15 years. Patient is a chronic smoker. There is a family history of pulmonary tuberculosis in his wife 7 years back, for which she took 8 months of ATT with complete resolution. Treatment history: patient is having history of incision drainage of the right foot with no improvement 2.5 years back, and there is a history of multiple topical and oral medication with no improvement. Examination vitals, general physical examination, systemic examination was normal. The BCG scar mark were present. The patient is having limping gait with restricted range of motion in the right ankle and in the right ring finger with lateral deviation. So on cutaneous examination, the right foot is grossly enlarged with swelling present over the midfoot area and with overlying multiple puckered scars with peripheral hyperpigmentation. Along with that, patient is having diffuse depigmentation over the bilateral sole and the lateral side of the foot and finger of the both the hand. Patient is having single discharging sinus, which is present over the right ring finger with swelling and lateral deviation of the finger. There is a single puckered scar with peripheral hyperpigmentation, and a pus point is present in the left hypochondrium. Mucosa, scalp, palm and soles and nails were normal. So based on the history and examination, we make a provisional diagnosis of query scrofloderma, query actinomycosis. Some stain from which came out to be negative. Wet gauze wrap test on day 1 were negative. In CBC, patient is having low hemoglobin with raised ESR and increased Montaux reading with viral marker were negative. First culture for mycobacterium and fungal and CV net and sputum for AFB were negative. Chest X-ray showing there is blunting of the left CP angle along with mild pleural effusion. X-ray of the hand showing there is a destruction of the proximal interphalangeal. There is a destruction of the periarticular bone in the proximal interphalangeal joint of the fourth finger. Along with that, there are few areas of osteopenia in the adjacent phalanx. X-ray foot showing there is a lytic bony destruction of the tarsal, calcaneum, proximal metatarsal, and there is a loss of intertarsal joint space along with overlying soft tissue swelling. Ultrasound test showing sinus tract which extends from the skin superficially in the left subcostal area. Along with that, there is minimal effusion in the left CP angle. On USG foot, there is a marked soft tissue thickening with ill-defined hypoechoic collection in the dorsum of the foot, and there is a marked cortical irregularities in underlying bone. Sorry. ECG, USG abdomen, and USG pelvis were normal. On MRI foot, there is a complete destruction of the tarsal bone, and there is a partial destruction of the calcaneum and talus with proximal metatarsal is replaced by phlegnous soft tissue. On histopathological examination,
Hello, Visal.
Yes, ma'am.
You are not audible. Are you fine?
Yes, ma'am. Yes, ma'am.
Okay.
On histopathological examination at 40x showing epidermis was normal. There is a mild chronic inflammation in the mid-dermis showing lymphocytic infiltrate in the perivascular area. Tissue CB-NAT were negative and the fungal and the microbial culture shows no growth. So TB being endemic in our country with presenting findings of multiple site involvement, multiple discharging sinus with overlying, sorry, so because TB is endemic in our country with presenting finding of multiple site involvement and there are multiple sinuses with underlying osteomyelitis and pleural effusion with raised ESR and Montos along with positive family history of TB in one of the close contacts supporting a diagnosis of multifocal scleroderma with underlying osteomyelitis with TB gamma with pulmonary tuberculosis in an immunocompetent individual. So patient is put on ATT category 1 with 2 months on HRJD with 16 months of HRE. So this picture shows the completion of ATT 6 months post treatment showing reduced swelling over the right foot with healed sinus. There is swelling of the ankle were reduced with sinuses were healed. On hand, the sinus were healed, but there is a shortening of the finger of the right hand. On X-ray foot, there is a swelling, a soft tissue swelling were reduced with mineralization of the tarsal bone. Along with that, we can also find the intertarsal joint space is also visible on the X-ray, which shows improvement. Although the soft tissue swelling on the right hand proximal phalangeal joint were reduced, but there is a fibrosis and ankylosing were developed in the periarticular area. So the purpose of the case is of this presentation to present a atypical presentation of scleroderma, which is mimicking mycetoma over the foot, along with multifocal involvement with a non-specific histopathology and negative culture and stain for mycobacterium. Thank you.
Thank you, Dr. Vishal, for presenting such a challenging case. I now request Dr. Bhavna, final year postgraduate student, to please present the fifth case of today's session. Dr. Bhavna, please.
Good afternoon, everyone. I'm presenting the case of 26-year-old male resident of Bihar who presented to the OPD with chief complaints of recurrent multiple painful nodules with discharging sinuses over back, buttocks, and groin for the past 3 years and current exacerbation for the past 2 weeks. The patient was apparently well 3 years back when he noticed development of multiple painful nodules and discharging sinuses, initially over the buttocks and progressed to involve groin, back in the span of 4 months. These lesions used to heal with scarring. A patient had taken multiple topical and oral drugs with partial relief in his symptoms. There was no history of acne, joint pain, past discharge from the scalp, a similar lesion on any other body site. His personal history, past history, and family history was not significant. On examinations, his vitals were stable and his systemic examination was normal. On cutaneous examination, there are multiple erythematous nodules present over the back and buttocks with size ranging from 1 × 1 to 3 × 3 centimeter. Also, there are multiple ulcers present over the buttocks with floor showing granulation tissue and pus discharge. Multiple intercorrected sinuses are also present. And there are multiple skin color to hyperpigmented scars present over back, buttocks, and groin with size ranging from 2 × 2 to as large as 7 × 4 centimeter. While examining the back of the patient, we incidentally noticed multiple open comedons, and examination of the groin revealed multiple hyperpigmented macules and pitted scars. A similar lesion were also present in the axilla. Further examination of the neck and retroauricular area showed similar follicular hyperpigmented macules and pitted scars, and also pitted scars were present over the face. Similarly, pitted scars were also present over the palms as well.
So on the basis of history and examinations, we made a provisional diagnosis of Dowling-Dego's with hidradenitis suppurativa stage 3. On dermoscopy, in the polarized mode under 10x magnification, showed multiple brown dots, Chinese letter-like pattern, irregular spoke wheel pattern, and follicular bridging pattern. Palmar pits were better seen in dermoscopy in this view. His routine investigations were normal. Skin biopsy for histopathology was sent from the hyperpigmented macule. This is a photomicrograph on 10x magnification showing filiform branching redder ridges giving an antler horn-like pattern. And also there is increase in melanin pigmentation in the basal layer of this infundibula of hair follicle with sparing of the interfollicular region. Multiple horn cysts were also present in this patient. So we made a final diagnosis of follicular Dowling-Dego's with hidradenitis suppurativa, early stage 3. We counseled the patient regarding the course of the disease that it is an autosomal dominant condition. We started the patient on tablet clindamycin 300 mg twice daily and 30 mg once daily. The purpose for this presentation is demonstration of a rare case of follicular Dowling-Dego's with hidradenitis suppurativa. This is the first case of Dowling-Dego's with Palmar pits, so we propose that there may be more to this disorder than we already know. In various studies, there has been reports of Dowling-Dego's with hidradenitis suppurativa having mutation in PSEN gene, and Palmar pits are associated with ectopigmentation of Kitamura, where there is mutation in keratin 5. So we plan to do genetic analysis in this patient, which could not be done due to economic constraints. Thank you.
Thank you, Dr. Bhavna, for presenting such a challenging case. I now request Dr. Priyanka, a second-year postgraduate student, to please present the sixth case of today's session. Dr. Priyanka, please.
Good afternoon, everyone. Today I'm presenting a case of Good afternoon, everyone. Today I'm presenting a case of 12-year-old male child born out of non-consanguineous marriage, presented to us with chief complaints of unerupted permanent teeth since 7 years, nail discoloration and thickening since 5 years, and asymptomatic thickening of both the palms since 3 months. Initially, patient had normal deciduous teeth, which shed off at 5 years of age, followed by eruption of only 2 maxillary molar teeth, which were associated with dental caries and difficulty in chewing the food. There was history of thick and brittle nails since 5 years, which gradually improved to current situation, and toenails were involved more than fingernails. There was history of thick raised lesion on the palm since 3 months, but there was no history of itching or contact with any history of intolerance to heat or abnormal perspiration. Past history, personal history, and family history were not significant. On pedigree analysis, none of the other family member was affected by the similar complaint. Vitals, general physical examination, and systemic examination were within normal limit. On oral examination, there was presence of oligodontia with presence of only 2 maxillary molar teeth associated with dental caries. The cutaneous examination revealed presence of multiple, well to ill-defined, discrete to coalescent, grayish-brown, thick plaque present on both the palms and the fingers, and the surface showed mild scaling. The yellow-brown discoloration of the nail plate with increased longitudinal region. Toenails were involved more than fingernails. Scalp, hair, and faces were normal. Since our patient had abnormality of 2 ectodermal structures, that is tooth and nail, we have kept a provisional diagnosis of Wittkopf tooth and nail syndrome with palmar hyperkeratosis. Fungal infection was ruled out by Doon KOH. The orthopentomogram revealed multiple missing permanent teeth, and skin biopsy for histopathological examination showed hyperkeratosis and acanthosis in the epidermis. So the final diagnosis of Wittkopf tooth and nail syndrome with palmar hyperkeratosis was made. The purpose of this case presentation was to demonstrate a real case of Wittkopf tooth and nail syndrome with an unusual association with palmar hyperkeratosis, which have not been reported previously. Thank you.
Thank you, Dr. Priyanka. Audience members, please send in your questions in the query box. I now request Dr. Priyadarshini, second year postgraduate student, to please present the last case of today's session. Dr. Priyadarshini, please.
Good afternoon, everyone. Today, I'm going to present a case of 75-year female who's a resident of Delhi, presented to our OPD with chief complaints of multiple itchy, clear fluid-filled lesions on the right side of the trunk from past 5 days. In history of presenting illness, she developed sudden onset of 2 to 3 fluid-filled lesions. Within a span of 2 days, there were multiple lesions involved in entire right side of lower abdomen, associated with burning and itching sensation. She had received first dose of Covaxin 5 days back with no recent history of trauma or psychological stress. She is a known case of hypertension with coronary artery disease, underwent coronary bypass grafting surgery 1 year back with no similar history in the past, no history of diabetes mellitus, no history of immunosuppressive drug intake, or no recent history of COVID-19 infection in the patients or in family members. Her personal and family history were not significant. In examination, her vitals were stable. General physical examination and systemic examinations were within normal limit. Coming to the mucocutaneous examination, there were presence of multiple vesicles on the right side of the lower flank in a dermatomal distributions along the T7 to T8 dermatome of size ranging from 0.3 into 0.5 centimeter containing clear fluid upon an underlying erythematous base. We kept a provisional diagnosis of herpes zoster following first dose of COVID vaccination. We conducted a Zank smear in our side lab in a higher magnification. It showed multinucleated giant cells with few acantholytic cells, which further confirmed our diagnosis. She received a treatment of tablet acyclovir 800 mg 5 times a day for a week with supportive therapy. And this is the picture which shows lesions before and lesions after 5 days of treatment, which healed with few crusting. Similarly, another case of 55-year male who's a resident of Delhi presented to our OPD with chief complaints of multiple itchy, clear fluid-filled lesions on the left side of the thigh from past 7 days. In history of presenting illness, he developed sudden onset of fluid-filled lesions on inner aspect of left thigh, just above the knee, associated with itching sensation. He had received second dose of Covishield 10 days back with no recent history of trauma or psychological stress. He had similar lesions on left shoulder 8 years back, but no history of immunosuppressions or any comorbidities. No recent history of COVID-19 infection in the patient or in family members. His personal history and family history were not significant. In examination, his vitals were stable. General physical examination and systemic examinations were within normal limit. In examination, there were vesicles in a localized manner on inner aspect of left thigh, just above the knee, of size ranging from 0.5 to 0.5 centimeter, with a clear fluid-filled lesions and underlying erythematous base. In investigation, we conducted a Zank smear in our side lab, which showed no acantholytic cells, and further advised for HSV serology, which showed IgG positivity. A diagnosis of herpes simplex following second dose of Covishield was done. Purpose of this presentation is demonstration of 2 cases of herpes zoster and herpes simplex respectively following COVID vaccination. The mechanism proposed were functional exhaustion of cytotoxic lymphocytes leading to reactivation of varicella zoster, and immunomodulation has a plausible mechanism and has also been suggested following COVID-19 vaccination. Thank you.
This concludes our last case of the evening. Since we have no queries, we'll go forward with the next. Yes, so some queries are there. Dr. Rekha has asked, what are the other manifestations of COVID-19? Dr. Priyadarshini, please elaborate this answer.
Is this regarding COVID-19 vaccination or COVID-19 infection?
Yep. Please tell the skin manifestations of COVID-19 vaccination as well as COVID-19 infection both.
Yes, ma'am. Ma'am, COVID-19 infections, obviously, it depending on the severity of the condition. If the patient has very severe COVID infection or mild or moderate, depending on that also, patient can develop cutaneous manifestations. And currently till now, the reported cases shows in mild cases, there are presence of perniosis-like lesions with acral ischemia and urticarial lesions. In moderate to severe condition, there are presence of maculopapular rashes or chilblain-like lesions with lividoreticulars also reported, with few in between cases also has pityriasis rosea-like, erythema multiforme-like lesions also being reported. In following a COVID-19 infection, there are multiple cases reported, which predominantly include immediate reactions of burning sensation, itching sensation, or redness. The severe cases include COVID arm, which represents a severe swelling, redness, and painful condition of the injected arms. Apart from that, maculopapular rashes, reactivation of herpes zoster, reactivation of herpes simplex cases also been reported now.
Dr. Priyadarshini, we have one more question for you. Dr. Abhinav has asked how many cases of herpes simplex have been reported with COVID vaccination?
Sir, till now, there are 4 studies of herpes simplex from worldwide, which includes total of 18 patients. In India, there are no cases of herpes simplex reported yet, sir.
Thank you, Dr. Priyadarshini. Dr. Molisha has asked, can you please show the histopathological images again, which is not specified which case? So Dr. Molisha, if you're there, please let us know which case you want to see histopathology images of.
Hello. Dr. Vinay?
Yes, sir.
I'm here. Whenever you want me to start, I'll start it.
Sir, I think as
Hello,
there are no
Garima.
more questions.
Sir,
Hello.
lastly, yes, sir.
Garima.
Yeah.
Yes, sir. So
Yes,
lastly, I
Are
wish
there
to
questions?
thank.
Are there some questions?
No, sir. I just want to thank the audience.
Okay, I am glad that at least a few cases related with COVID, not directly related with COVID, but related with COVID vaccine were discussed. As Dr. Vijay Lakshmi was saying that this hospital was designated as a full-fledged COVID hospital, so we expected some more cases. Nevertheless, I welcome Dr. Anil Ganju sir, our past president of Delhi State Branch and vice president of National Iadvl, to deliver his talk. Dr. Ganju sir, please.
Dr. Priya, you wanted to say a vote of thanks. Please do that before I come
Yes,
in.
sir. I wish to thank our adorable HOD ma'am, Director Professor Sahu ma'am. She pays attention to the intricacies of the subject. Her constant inspiration, motivation, and constructive criticism has allowed us to make our presentations perfect in every way possible. I thank our dedicated residents, faculty members for their constant hard work, the audience for the patience and active participation. Hope you all have enjoyed today's session. Thank you, everyone. Now I request Dr. Gaurav sir to please introduce the next speaker.
Okay, I'm already introduced. So can I request whoever is sharing the screen to log off from the screen, please, so that I share my screen.
Yes, sir.
So a big thanks to Team Delhi, Dr. Vinay Singh and Dr. Gaurav Nakra for giving me this opportunity to be a part of the meeting today. It's been a long time since I've been a part of these meetings, because earlier we used to be there on every Saturday when we used to have it. But unfortunately, because now we are busy in our individual practices, so it becomes difficult. But nice to be back with you. My regards to Dr. Vijay Lakshmi Sahu and the team from MAMC. I'm going to talk about something that is talked about quite often, that is chronic spontaneous urticaria. But what I'm going to, is my screen visible?
Yes, sir, it is visible.
Okay, let me make it full screen. So friends, chronic spontaneous urticaria is quite a common condition, and we keep on, hearing about this problem day in and day out. And over the recent past, we have been talking a lot about updosing of second generation antihistamines in chronic urticaria. But understanding why we do it and what exactly is the reason for updosing, I thought we should bring it to the fore and discuss this at length. So you all know that chronic urticaria is the occurrence of recurrent transitory cutaneous wheals, redness, itching, frequently with angioedema happening on almost daily basis, lasting for more than 6 weeks, has a huge impact on the quality of the life of the patient, with disturbance in sleep, diminution of the productivity at work and at school in children. It's a common disorder. If we put all urticarias together, about 15 to 30% of the population worldwide is affected by this condition, and chronic urticaria is seen in up to 0.5 to 1%. As I said, it affects the quality of life to a large extent, and the severity of impairment of life quality has been compared to triple vessel coronary artery disease. Extremely distressing for the affected patient, and also challenging for us physicians, because many a time what happens is that although this is a chronic condition, the patients are not ready to accept its chronicity, considering it a simple skin problem, and they're not ready to accept that they have to take medication for a long time. Depending upon the causes, we have different types. We have the autoimmune variety, where antibodies are directed against either the IgE receptor on the mast cells or against the IgE antibodies. We know about this. We have physical urticarias, we have chronic infections causing urticarias, we have idiopathic vasculitis, etc. In the recent update on pathogenesis, we now know that mast cells, neutrophils, adhesion molecule expression, IL-8, chemokine factors, all these play a role in the potentiation of chronic spontaneous urticaria, and memory cells have been found in the peripheral blood of the patients of chronic spontaneous urticaria. So they might be having a role to play in this chronic disease. Also, oxidative stress has been found to be present in the lesional skin of patients of chronic spontaneous urticaria, which means that probably the oxidative stress is also playing a role. Basophils have been implicated to a large extent, and now we know that basopenia points to more severe disease, more seen in autoimmune chronic spontaneous urticaria, and we do also have a basophil histamine release test as a very useful test to detect severe urticaria and autoimmune urticaria. Most of the anti-allergy bodies worldwide, be it the European Academy of Allergology, be it the European Dermatology Forum, be it the American Academy of Allergy, Asthma and Immunology, they all recommend the usage of the second generation non-sedating antihistamines, and nomenclature of the disease has been changing as we have been progressing and understanding the disease. Now we don't call it chronic idiopathic urticaria because we know the cause in most of the cases. The cases which were thought to be idiopathic are probably autoimmune now. And so we call it chronic spontaneous urticaria. They say that investigations should be avoided in acute urticaria, which is when urticaria is of less than 6 weeks duration, and the test should be done only in chronic urticaria, where we do a routine count, an ESR, a CRP, and extended diagnostic workup should be done only if the history suggests or the investigations show something sinister. Now, the goal of treatment is complete absence of disease. You have to take care of the signs and symptoms and treat the disease until it is completely gone. And most of the recommendations worldwide are that we should use a second generation non-sedating antihistamine because it is associated with less side effects. Before we understand the science behind updosing, let's understand what is histamine and how antihistamines work. Now, histamine is a natural body constituent which is synthesized from the amino acid histidine. It plays an important physiological role in a number of physiological properties in the body. It has involvement in the health, disease, etc. It exerts its effect through 4 subtypes of receptors. So we have receptors right from H1 receptor to H2, 3, 4. These are distributed all over the body, right from central nervous system to central vascular, cardiovascular system, to various inflammatory cells, neutrophils, eosinophils, B cells, etc. The gastric parietal cells, for where H2 receptor is predominantly present. And then there are H3 receptor, H4 receptor, which are distributed. So they have a number of properties to and role to play in our daily physiology. As I said, most of the bodies across the world now do not recommend using the sedating first generation antihistamines because they have a number of side effects associated with them, and most of them say that second generation antihistamines should be used. These second generation antihistamines were developed in early 80s to overcome the sedative and anticholinergic effect that the first generation agents would produce. So earlier we used to use the first generation antihistamines, but because they had these problems, so they developed the second generation antihistamines. The second generation antihistamines, in addition, were found to have a high receptor selectivity, faster onset of action, and longer duration of action, and the lesser side effects, as I've already told you. These second generation antihistamines were found to have a wide safety window so that they could be given at a higher dose also. Therefore, it was recommended that we can increase the dose of second generation antihistamine 4 times if the regular dose does not work. And this was recommended on the basis of some science that we are going to discuss. Why do we updose? We updose because many of our patients do not respond to the regular dose of antihistamines. So if we give antihistamines to about 100 patients, only about 45 patients will respond to a regular dose of second generation antihistamine. And if we updose the second generation antihistamine to 4 times the dose in these patients, about 60% will start responding. So that's a good about 20% which will be responding to the treatment. The concept of updosing has arisen from the discovery of the phenomena called inverse agonism. So we have to understand what inverse agonism is, and then we'll understand why we updose and how much should we updose. Traditionally, if we see, the conventional receptor blockade was thought to be because of a mechanical blockage of a receptor. So if you have an antagonist to an action of an agonist, the antagonist would go and occupy the receptor and block the receptor so that the agonist could not get attached to the receptor, and thus the activity caused by the agonist is not caused because it does not get attached to the receptor. But lately it has been seen that the receptors can by themselves display constitutive activity. That means they by themselves can produce symptoms without the ligand or the agonist getting attached to them. So they basically are active. The receptors are not just receivers of the activator, but they are themselves active. So we have 2 types of molecules. A molecule which causes an activity in the receptor, for example, histamine getting attached to a histaminic receptor and inducing an urticarial rash, or we have the antagonists which get attached to the receptor and decrease the activity of the receptor. I'll explain it further here. So there is this two-state model of the histamine receptor which has been proposed, where they have said that a histamine receptor has two states, an inactive state and an active state. And at any given point in time, there is an equilibrium between the inactive and active state. And if there is more activity, then an urticarial rash will happen. And if there is more inactivity, the urticarial rash cannot happen. So what happens in an urticarial patient, the agonist or histamine gets attached to the receptor and shifts the equilibrium from the inactive to the active state. So there is activation of the receptor and shooting off of the urticarial rash or urticarial symptoms. And what the antihistamine does, it does not block the attachment of the histamine to the receptor, but what it does, it induces this inactivity in the two-state model so that histamine cannot activate the receptor. So because of this, as we increase the dose, as we keep on increasing the dose of the antihistamine, which is the inverse agonist, the more and more inactivity results, so that histamine, even if it is present, it cannot activate the receptor. So we are not mechanically blocking the receptor and not allowing the histamine to sit on the receptor or get attached to the receptor, but we are inactivating the receptor by this inverse agonistic effect of antihistamine. So I hope you understand that antihistamines are not mechanical blockers of histamine receptors, but they are inactivating the receptor by this inverse agonism. So that is what the science behind the updosing is. So across the board, most of the antihistamines or all of the second generation antihistamines have been found to be more effective as we increase the dose. Fexofenadine 120 to 240, the activity, the response rate improves. Similarly, desloratadine from 10 to 20, the response increases. Belastine from 40 to 80, the response increases. Rupatadine from placebo to 10 to 20, the response increases. Fexofenadine, as we keep on increasing the dose, the response increases. And mind you, as we would increase it more than fourfold, also the activity or the antihistaminic effect would be further increased. But we increase it fourfold because up to fourfold, it has been seen that these second generation antihistamines are not associated with any major side effects. It is also important to understand that updosing with single antihistamine is better than combining several second generation antihistamines at the same time. This has been proven by several studies, and there's a very important study which was done by Schulz et al. What they did in 67 patients of pruritus of varied origin, they had 3 arms, and in one arm they gave double the dose of levocetrizine and double the dose of fexofenadine. In one arm, they gave double dose of levocetrizine, double dose of fexofenadine, and double dose of azelastine. And in the third arm, they gave quadruple dose of desloratadine. So what they found that the best response was seen in the quadruple dose of desloratadine, with 76% of the patients responding and their pruritus going down, compared to 2 drugs used at double the dose, which was 43%, or 3 drugs used at double the dose, which was still not as good as a single drug. So this is a graphical representation of what I've already told you, a 76.9% response with a quadruple dose of desloratadine compared to 2 drugs used at double the dose, 43%, 3 drugs used at double the dose, 68%. So best is updose a single drug. So it is thus proven that a single drug updosed 4 times is much better than using several combination of other drugs. The second generation antihistamines also have the advantage of having a rapid onset of action and persistence of effect of up to 24 hours. So therefore you can administer it just once a day compared to the first generation antihistamines. They have not also been seen to develop tachyphylaxis. They also have a very favorable safety profile. So even at higher doses, which is useful in updosing, they do not produce any side effects. Anti-inflammatory effects have also been seen, and thus that helps us take care of the non-histamine mediators of allergy. So if we compare different second generation antihistamines, the fexofenadine and belastine, they stay stay apart from others because they have the advantage of being associated with lesser side effects, particularly sedation. Levocetirizine at the higher updosed version does produce some sedation. Fexofenadine and bilastine do not. Bilastine further has an advantage that it does not have many drug interactions. So in situations of polypharmacy in elderly, you can easily use it. Similarly, hepatic and renal impairment does not affect fexofenadine and bilastine to a large extent. So these two drugs stand apart as far as updosing is concerned. Therefore, friends, second generation antihistamines are the recommended first line drugs. Current data provides convincing evidence that quadruple dose works the best for patients who have not responded. The science of updosing is related to the understanding of this phenomena called inverse agonism, which I've explained. The antihistamines block the histamine effect on receptors not by mechanical blockade of the receptor, but by inducing inactivity in the receptor at higher doses. So that's why we updose, and higher dose of antihistamine, higher the dose of antihistamine, the better is this inverse agonism, and more is the inactivity of the receptor. So better control of symptoms. So that's why we updose. And that's it. Thank you very much for your kind attention. Over to Dr. Vinay.
Thank you, sir, for a very nice overview about updosing of the antihistamines and new insights in chronic spontaneous urticaria. Now I request Dr. Gaurav Nakra, our dynamic secretary, to take the proceedings further.
Thank you, Vinay sir. Thank you, Anil sir. First of all, accepting this invite at such a short notice, and second, giving us this great lecture. I'm sure all the PGs, residents, senior residents, and consultants would be benefited by it. In the end, I would again like to thank the entire department of MAMC for conducting this clinical meet. And on behalf of Iadvl DSB, I take your leave. Thank you so much.
Thank you very much.